This is Dr. Christopher Jones. I just wanted to show everybody some pretty exciting new technology. One of my favorite procedures to perform and put a ton of time into learning everything about it is a total shoulder replacement. I became interested in doing shoulder replacement as a resident at Duke. The challenge with shoulder replacements really is putting the prosthesis in as perfect as possible. It's hard to describe, but when you're looking at the glenoid or the socket from a surgical viewpoint, it's very difficult to appreciate anatomy and appreciate if there's been wear. Because what happens with shoulder arthroplasty, or shoulder arthritis I should say, is that as it progresses, the glenoid vault starts to get eroded or worn down, and that can create some serious problems. You start losing bone, and you have very little bone to work with even at the beginning. So it'll be a little more clear when I start showing you some of the CT images. But in any event, Exactech is a great company. They really lead the charge in shoulder arthroplasty or shoulder replacement. Just as a disclaimer, I am a consultant for them. I don't receive any royalties or anything like that, but just help them with product development and education. So on to the pre-op software. So the problem with shoulder replacements is you can end up with glenoid erosion, and this is actually really the heart of this platform. Basically what you do is you get a CT scan of the patient, or the patient's shoulder and scapula. And this is a very specific sequences, very, very fine cut, 0.5 millimeters. And then they can do this 3D rendering on the computer. And we can actually take this and and look at it in whatever plane we want. It's really, really cool. When it comes from the software company, it puts this this line, which is down the center of the glenoid, and down the center of the scapular body, and that kind of tells you the axis of which we measure from. But what happens in advanced arthritis, and you can see here, this is an example of a patient that I've done, is you start to get posterior erosion or posterior wear. Again, you can see here's the face or the flat part of the socket or the glenoid, okay? So this is your scapula. This portion has eroded right here. It really should be more this way. This measures about 20 degrees of retroversion, and normal is only 4 degrees. So if you just go ahead and put it in this position, number one, you're going to get abnormal loading on that from the humeral head, and abnormal biomechanics with the shoulder. So patients won't get their range of motion back, they won't get their strength back as well. And a glenoid component that is not placed in the anatomical plane is more likely to fail at an earlier date. Because you get edge loading. So just as to show you an example, I can take this software and I can actually install a glenoid. So this is actually a wedge glenoid. Don't want to start there, so we'll switch it to the regular. And you can see after you can kind of look around and you can change its orientation. But if we just ream it down flat, and all these over here are on the right hand side of the screen. That's how you adjust the position of the glenoid. And again, this is for preoperative planning, so you can actually put it a little deeper, and that was less deep, a little deeper like this. You can see to get it flat. And so when you get it all the way flat in a decent version, let's set it. Let's put it back at anatomic. It's 4 degrees. And we said you need to go deeper and deeper and deeper and deeper to get it down. And then what happens is your pegs are exiting out the base of the glenoid right here. And you're having to ream so much bone. Look, you're reaming so much bone that this is actually sitting underneath the surface. Well, I mean, if you don't know this going in before surgery, you can look at the face of that glenoid, and you really don't know that it's worn, because from the viewpoint of the surgeon, you're basically, all you see is this. All you see is this, just the face. You don't see any of the scapular body down here. You can't see this coracoid process. You know, the chromium is covered with the deltoid. So really, this is all you see. So it can be really difficult to put this in a proper way. So that, you know, what I've seen done and is you just put it on flat. Let's see here, something like this. And you have to basically just put it in the version that you see. Like so. And from this perspective, it looks great. You know, it looks great. But if you haven't had a CT and you haven't really assessed it and you haven't used software like this, you're going to put it in retroversion. So this component, as you can see over here on the right hand side of the screen right now, is in 30 degrees of retroversion. So there's a couple things you can do to fix that, and that's why this pre-op planning software is so vital and so valuable. I'm doing the surgery before I even go in the operating room. So we have these components that are augmented, where we can, it has a build-up in the back, which you can see over here. And then you can try to get it closer back to anatomic version. So we'll kind of put it back, and we'll try to get it in the ballpark, you know, 4 degrees. And then you can see, okay, how much bone do I need to ream to get this thing to sit, okay? So you want to look at it like so, and then just a little bit more, a little bit more, a little bit more, a little bit more. And see, even now we're putting it in the regular version. You can see that it's, with this augment, it's still penetrating through the glenoid vault, which decreases survivability of these. And you're also having to ream a ton of bone, which is indicated here, where you just you can't see the glenoid component any longer because it's deep to this bone. That means you've reamed a ton of bone, and you can get an idea here. I mean, so you're reaming it down and losing a lot of bone. And two issues with that. One, you're getting down into this really soft, what we call cancellous bone. And cancellous bone is not good for support, and long-term, what we see is subsidence, meaning that the component just kind of sinks further and further and further, you know, into the bone like this, and subsequently becomes loose again because it's not well supported. So the alternative is, again, using this preoperative software. You know, you can maybe accept a little bit less than anatomic. So kind of increase your version a little bit and kind of see where we're at. Let's put it at 8 degrees. You know, and it's not too outside of what we would accept within the normal limits. And then kind of slowly take it down till you get as much coverage as you can. So here, still reaming down some bone, not as much, not nearly as much. Actually, I would fair to guess that some of this is osteophyte that you're reaming out. But we're also still slightly penetrating the vault, and that tiny bit doesn't seem like much, but it can compromise long-term viability of your implant. So, I mean, again, our goal is to put one in as perfect as possible so that it has a better chance to last. So I'm just going to change my version just a little bit. I'm going to put it at 10. You can also kind of change the position. Let's say, what if we just slightly move it forward? So you got a little overhang here on the front now, so you don't want to do that. But you know, one thing, this is an extra large component. We'd probably be better off in this patient doing a medium. And again, all this is helpful. So I moved it a little forward. So now I'm going to push it a little further back. There we go. So again, I think we're just reaming down mostly osteophytes there. Let's see if we're in the vault. Still slightly out of the vault. Typically, it doesn't make a difference to switch to a smaller component with this, but we'll check and see. What it does, you know, it allows you more freedom in where you place it too. So if we did a medium here and we went a little bit more anterior, they're all within the vault. You're reaming down a little bit of bone, but not too much. Again, I think a lot of that is osteophyte. See what a large looks like again. Yeah, it's well contained. So I'd rather ream down a little bit of bone like that and get pretty close to normal version than put in a component in retroversion. If it comes to the fact that you just can't correct it, it's just too much wear, then the best option for those patients is to consider doing what we call a reverse replacement. And that's where you put the ball on the socket side in the socket on the ball side. See over here on the left hand side, we can switch to reverse. We'll put in just the standard component, which is here. And the beauty of the reverse is you can actually put it in retroversion, and patients still do exceptionally well. You're just not as reliant upon rotator cuff muscle function when you're dealing with reverse replacements. So that's just a standard implant. Again, it's in 19 degrees of retroversion, but we can also use a posterior augment. We can kind of partially correct, which you can see here. The other thing with the reverse is after you put your plate on, then you put your glenosphere, or the ball, on this side, but you're fixing this with screws. You can put up to 6 screws in this component. Usually if you get 4 good ones, I'm happy with that. I'd rather not fill every hole if possible. The holes are really more there to give you options. But because you have screw fixation of this, as opposed to just relying on press fit or cement with the standard prosthesis, you don't have to have absolute 100% support because you get so much, such solid and rigid fixation. Anyways, really exciting. This really changes things with shoulder replacement. There's other systems out there that you can do this on. But most of those systems don't have the repertoire in terms of augments available, augmented reverses. The system is interchangeable. You can actually change on the fly in the middle of surgery. But then even more exciting, what these Exactech's kind of taken it to the next level, is you can take this plan and just in and of itself, it's extremely valuable. Being able to use this to just to plan pre-op, because you know if you look at enough of these and you set your plan pre-op and you get in there, you can pretty much nail it if you do a lot of them. But just to take it to the next level, and I think it's going to be very valuable when you're dealing with really bad deformities, is then you can take this plan into surgery, and you can actually see live guidance when you're reaming, when you're placing your guide pins, and then when you're placing screws. You can see this shows a picture of the reamer, and you can kind of adjust according to, you know, the depth, the retroversion, the inclination, and all this, and it can just take you step by step through the plan that you did on the computer. But just amazingly cool stuff. So anyway, that's an update on what we're doing in shoulder arthroplasty. Again, I think this is extremely exciting. You know, I personally think Exactink has the best components. The glenoid component, which is the key to total shoulders, is in my opinion the best out there. I personally have ones that are 5 years out that look like they're 1 day old, and patients do great with this prosthesis. So please email me if you have any questions, and I'm certainly happy to answer. If you need me to look at your shoulder, you can certainly call my office, and I'm happy to get you in. Have a great day. All right, 6 months out from total shoulder arthroplasty. Do you having much pain at all?
None.
Awesome. Let's see your motion here. Let's have you raise all the way up. Actually, do both arms. There you go. Come down. Come out this way. Behind the back. So you lift up away from your back. There you go. About hand on your belly. Press down. Bring that elbow out. Awesome. Are you happy with it?
Very.